This episode is brought to you by Dr. Chrono, powered by EverHealth, the first and most advanced all-in-one mobile EHR system. Dr. Chrono's cutting-edge technology streamlines your workflow and automates tasks, helping you maximize efficiency wherever you are. Discover why so many primary care practices rely on Dr. Chrono. Start your 30-day free trial today at drchrono.com/free trial. That's drchrono.com/free trial. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is being a personal physician to patients, a friend with a specialized knowledge. I am Dr. Joseph Rotella, and this is my DPC story.
Dr. Joseph Rotella is dedicated to addressing the fundamental building blocks of healthcare, including disease prevention, chronic disease management, service delivery, workforce development, and leadership. With a passion for inspiring and motivating individuals toward a healthy lifestyle, Dr. Rotella believes in making a positive impact one person at a time. With extensive experience in healthcare, Dr. Rotella specializes in family medicine, chiropractic care, and integrative and lifestyle medicine, offering a multidisciplinary approach to patient care and disease treatment. Known for excellence in office administration and medical operations management, Dr. Rotella consistently achieves fiscal and organizational goals while avoiding unnecessary costs. A strong leader with a proven ability to train and direct top-performing teams, Dr. Rotella excels in establishing and managing relationships with decision-makers and strategic partners. Recognized for integrity, problem-solving abilities, work ethic, and analytical skills, has earned a reputation as a trusted professional in his healthcare community. He opened Direct Healthcare in the fall of 2021. Thank you so much, everybody, for tuning in. Find out more about DPC, including resources, discounts, my favorite tech tools, and more at mydpcstory.com. Follow us on your social media platforms at mydpcstory, and be sure to subscribe to our newsletter and, of course, the podcast feed so you won't miss when the next episode drops. With that, I am so excited to welcome another fellow Blue Jay. Welcome to the podcast, Dr. Rotella.
Thank you so much. Thank you for having me.
So I absolutely geek out when anyone from Nebraska or anyone who went to Creighton is on the podcast. So I'm super excited that another person who understands where Creighton was situated, and you don't have to be religious to understand this. The idea of mind, body, spirit was very big at Creighton. And I remember I talked to Dr. Andy Bukowski about this, who had gone through a history of Jesuit schools. But for me, not being Jesuit, just getting into medical school there, I was really inspired during my entire journey in healthcare to take care of the whole person. And I really love that in your clinic, you've found a way to do that exactly. And you've done that under the DPC model after having experience in other models of healthcare. So I wanted to start with, you have a history where you're not only an MD, but you have your doctor of chiropractic medicine. So tell us about your journey getting into your DC first.
Well, thank you for having me. It's not really a long story, but it kind of goes like this. When I was at Creighton University, they make you take a lot of theology classes. So I had a minor in theology and philosophy, and my major was chemistry. And I also worked at my family's bakery full-time. Well, I shouldn't say full-time, but on vacations full-time, part-time. And then I also got on the soccer team to play Division I soccer. My grades weren't, I wouldn't say stellar, but I was persistently a good student, but wasn't the best of students. My brother visited a chiropractor, and I always wanted to be a doctor ever since I was a little kid. So that was like, there was no question about that. I knew I wanted to help people. And I remember going into a family physician's office, and there was young persons and old persons. And I was like, I can just treat everybody. And this kind of like, this stuck with me as a little kid, just to be able to help everybody. So when I was getting to graduate and applying to medical school, my advisor told me that I didn't have good enough grades. So I was a little disappointed, and I decided to go to chiropractic school. So I went from Creighton University just down south of Kansas City, which I loved the Kansas City Chiefs ever since then. I didn't miss a home game while I was there the whole entire time. We scrounged tickets every single game and back in the 90s and loved every minute of it. And today I'm a fan, even though not on the bandwagon. I've been a true fan since the early 90s. And during chiropractic school, I got straight A's pretty much. And then when I was going to graduate chiropractic school, I realized there was a school in the Caribbean, and I never really seen the ocean, believe it or not, because my dad worked in a factory and I worked with him and played soccer as well as studied. So when I found there was in the Caribbean, I immediately applied to medical school right after chiropractic school, hopped on a plane and began my medical school in St. Martin, American University of the Caribbean. A little to find out, you only do 2 years there. Most of the teachers are retired American teachers from America, obviously. And then we came back here and I rotated through the United States in my last 2 years and took my boards and got a family practice residency at Scottsdale Healthcare. And that's where I did my medical residency at Scottsdale Healthcare. When I was there and graduating after 3 years, they voted me to be the most successful entrepreneur. So when I was there, they gave me a stipend back in 2005, 2002, 3, 4, and 5, they used to give stipends to open up practices rather than buy out a practice like they do today. So they gave me a stipend to open up a practice, being likely to be the most successful entrepreneur. So I started from scratch, my own family practice in 2008 with 0 patients. And I grew that clinic to 4 providers and a total of over 25,000 patients, something like that.
It's just incredible. And I want to go back to this idea that you were given this entrepreneur honor, but also that, how you went into using that funding, because most of us in the DPC movement are MDs, DOs without an MBA. And I'm wondering, was it anything in particular that you were recognized for to get that entrepreneurial award? Or was it because of what you were intending to do after, because you had seen like how businesses run in your family's bakery, and definitely how businesses run in the chiropractic world?
It's interesting. They call me Dr. Efficiency. Everything that I did, I used to tell the residency director that this wasn't very efficient. This wasn't efficient. This wasn't efficient. So I tried to do as much as I possibly could do to do some policy changes to make it more efficient. And the most important thing in medicine is taking care of a patient, is to treat somebody. And I always said, like, family medicine is not treating age groups between young and old. Family medicine is treating somebody like you're a family member. So we want to treat people like family members, treat them as our friends, and put them as a patient-centric approach. And that was very difficult to do, even in residency, sometimes with all the rules, regulations, policies, and some of their procedural things that we have to do. So I found that very difficult, but I swore that when I get out, I was going to, when I did, open up an integrative practice to put patients first. But little did I know, that's very difficult to do in the insurance world, because the insurance world, we all know there's a host of issues that you have to jump through in order to put the patient first.
So true. And pretty much everyone who's listening to this podcast is probably nodding their head. When it comes to how you use the funding, were you given, here's money and you have to achieve certain things, here's money and you have to prove or track your data in order to, earn this money, so to speak, like if somebody got a grant? Or did you get the money and you were able to use it carte blanche? Stay with us. We'll be right back. Are you looking to expand your patient base and grow your business in 2025? Meet Decent, the health plan that puts DPC at its core. At Decent, they've built their plans around the DPC model, offering employer groups direct access to DPC practices like yours, 40% lower premiums compared to traditional options, 0 out-of-pocket costs for members when care is DPC coordinated, and a new HSA-eligible plan that maintains DPC as the foundation. By partnering with Decent, you can tap into their ever-growing member network, all while preserving the essence of DPC. Decent is not just another health plan. They're champions of the DPC movement, creating win-win solutions for practices, employers, and members. Ready to grow your practice? Visit decent.com/DPC. That's DECENT.com/DPC to learn how Decent can connect you with new patients and empower your practice today.
Well, Well, the first thing that I did was set up a line of credit. So because they didn't give you money, they just reimbursed you. So there's a difference. So they didn't give me money, but I had a spreadsheet basically. And then I had to figure out what I needed to utilize my line of credit for it in order to start my practice. And then I would send all my payments and my payment stubs to Scottsdale Healthcare. And then they would analyze it and figure out what they're agreed according to their lengthy contract, what they would pay for. Sometimes they didn't pay for some things that I wanted, like a decorative brick wall in my waiting room. They said no. But other things, most of the things that it takes to run an office, they did. And then they make sure you have a little bit of a salary for 3 years. And then as long as you accept their insurance programs, I had to accept every insurance program for a certain period of time. I think it was 10 years or something, 5 to 10 years, and then you can opt out. So the money was basically spent back then on the most inefficient things that I realize now: computer system, servers, staff, which is, health benefits for your staff, a little bit of marketing and equipment, stuff like that. I learned so many lessons. I mean, I almost wanted to write a book on just the lessons that I learned in the first 90 days of opening a practice from scratch in 2008 when the market collapsed. Right, switching to Obamacare with the market collapsing. And then also that was the time where the opioid crisis was booming and you couldn't give out opioids and everybody was seeking opioids, but you couldn't give them. And then you had to wean everybody off. And it was kind of a chaotic mess at that time. But I mean, I persisted with the market crashing and all those issues. And I realized that being efficient in medicine is being less profitable.
When you say that, could you give us an example of how in your clinic you've seen that demonstrated?
Oh, absolutely. When I was a medical doctor and a chiropractor, I had a chiropractic table with a room. I had my medical room and I love sports medicine and injections. So like right now I do ultrasound guided injections for all my patients. I love, I got certified in Botox for migraines. And so I always love doing injections. But back then the medical industry, as well as the medical legal industry with these attorneys, they said, Joey, you're a chiropractor and a medical doctor. You'd be great for MBA cases. And a lot of these pain management doctors, they would say they would refer me patients, their MBAs, attorneys would refer MBAs. So when I saw a patient in my office, I'd usually give them a chiropractic adjustment, evaluation, of course, x-rays, imaging as needed. I'm give them a chiropractic adjustment. I would get out a couple trigger points on the sore spots, give them maybe just a little bit of muscle relaxer before they go to bed. Maybe some anti-inflammatories. I'd give them a chiropractic adjustment. I had some therapy. I gave them on a handout to do home exercises and stretches. And in the following weeks, my schedule was kind of bare. So we used to call these people up and I used to ask them, I said, are you guys coming back for follow-up? And they're like, well, you gave me the home exercises, that trigger point really, really good. The muscle relaxers were working really good. And they don't need to come back. They don't need to follow up as much. And I said, oh, okay, that sounds good. Then the attorneys called me up and they said, your claims are so low. Usually we can only file them in the thousands of dollars. But I thought that you would do multiple visits for multiple trigger points or multiple manipulations or multiple visits. And I'm like, they got better in just a few. And so they diverted away from me. And then I realized the best doctors, the most efficient doctors to get the patients better had the least amount of visits that would equate into less profitability.
I just think about how residency is it's scheduled by other people. We show up, we have a certain amount of things that we need to do in whatever rotation we're on. Did you get the sense that racket that we call fee for service was going on to this extent where you realize later on that really, if you're going to be more efficient, you're going to be less profitable?
No, I didn't think about that. I mean, I felt like now I kind of relate to like my teenage daughter, and she does some things that are kind of dumb. And I'm like, oh, dear Lord, you don't understand the big picture. And I really did not understand the big picture, especially being, the big picture for, let's say, procedure-based specialties is a lot different than somebody who uses their medical knowledge and looking at somebody's lifestyle. There's an acronym that I always do for all my patients. I call it PENCIL. It's one of my things that nobody really knows about. So I'm telling you, and you can share it because this is going to be live. But on most patients, I look at prevention for all aspects of their health, as well as their specific condition. For example, if an old man comes in my office and says he has low back pain and his wallet is 3 inches thick with credit cards and bills, I tell him to take out the wallet and then the back pain goes away. But prevention, exercise, nutrition, counseling, motivational counseling, and setting up challenges, integrative medicine, and lifestyle management. That's my pencil. So that's how I promote lifestyle medicine to my patients, as well as promote trying to figure out what is the root cause of their particular disease. So I look at prevention, exercise, nutrition, motivational counseling, integrative medicine, and lifestyle management, which basically includes sleep and stress.
And hard to cover those in a 15-minute or less visit. So, my next question to you is, how did you take this realization that efficiency is not going to equal more profitability, and in fact could be less profitability as a result, and then go into your journey to direct primary care?
Well, the efficiency was geared towards, okay, I'll put it to you this way. There's a couple sticklers that I have. One stickler is primary care, just the word primary care. I like the word personal physician because primary care is more of which we need. There's no doubt about it because the other people understand that, the community understands that. But it translated into being a very efficient administrator. So as you know, and I know, every single time I loved headaches. So I've been to the American Headache Society meetings like year after year. I've been to pain management society meetings because like I want to learn about different types of injections and pain management. But every time that I go to a family practice one, it's about CPT, it's about coding, it's about all these things, but not knowing on how to improve the life of our patient. So primary care basically turned into a big efficiency administrative tasking pool of data collecting rather than putting a patient-centric approach. So I'm fast forwarding a little bit, but I have to say that one vision I think every direct primary care physician should grasp around is reducing unnecessary insurance claims. The reason I say that is because we all need some level of insurance. We all do. I think that I'm not saying about universal coverage. I mean, you can have catastrophic insurance. You can have, even if you got bad insurance, at least you got insurance, you know? But this thing is like, does DPC replace insurance? No. But you need a friend outside the system and a friend or a personal physician to reduce unnecessary claims. The cost of unnecessary claims, according to a few books that I read, are $110 billion, unnecessary care. In the book, I said unnecessary care, but I say unnecessary claim. For example, we know big health systems who see a patient as primary care. They do their risk management, the RAF scores, all these things. They document, and they don't have any time. So they refer out to neurology, they refer out to ortho, they refer out to derm, they refer out to OB. And what that basically means is claims. So direct primary care is trying to reduce unnecessary claims. And I think that's a big step that we can wrap around to solve healthcare.
It is beyond true. And I think that once you start thinking about DPC, even if one is not yet a DPC physician, I think that when you start thinking about things under the DPC way to do things, you really, that truth really becomes so apparent.
Well,
It's unbelievable.
If you look at the first idea in my particular vision or the mission for my direct healthcare practice is increasing value for each particular patient in healthcare. So value and quality care that has access. And access means like they can call me or text me, as we all know in this DPC world. So increasing the value by having access to high quality care. And number two is reducing insurance claims. Now, if your goal is to reduce insurance claims, that means that you as a personal physician need to learn more, do more, be more for that particular patient. So we need to do specialized, what I call AOIs, specialized areas of interest. Because in my group, I love migraines. You know, I've been doing migraines since 2008, well, a little bit earlier, but they'll refer me a migraine patient or they do refer me a joint injection. You know, a lot of for my well women, I refer them to somebody else. Somebody in my office loves skin biopsies. We refer them. It doesn't cost patients anymore. So we can do family physicians who are personal physicians and have special areas of interest is really important. So it's kind of like a match. Like a patient needs to know a family physician by what they do or what they have a specialized knowledge in, because that's what makes us unique. And that's what makes every DPC practice unique.
And I think it really adds to this level of transparency and autonomy that we bring to the table, because when we are, like you said, apart from the insurance driven world, we're able to look at things differently, look at claims differently, look at unnecessary care differently. I think that really feeds into the word of mouth and the trust that our patients have in us, because we help them be advocates for their own healthcare journey.
Well, yeah. And, you know, I love the lecture. I don't know if you saw the lecture that was at the HINT conference last summer, but that word advocacy means so much that people don't really understand what true advocacy really means. I mean, true advocacy means telling a patient, I don't know the answer, but I'm going to go home and research it. I'm going to call specialists up. I'm going to figure out a plan, you know, later tonight, and I'm going to get a hold of you tomorrow. That's being a huge advocate. Calling somebody and just seeing how they're doing and following up with them. That's being an advocate. Calling their loved ones or caregivers, you know, that we have permission to, of course, to check on the patients. That's being an advocate. Calling their pharmacy up, making sure that, they get their medications on a timely manner. That's being an advocate. There's lots of different ways that a physician can be a personal advocate to the patient, not just being present in that office visit, but outside the office visit. There's a lot of things that we do that to advocate for our own patients' behalf.
It's so true. It's so ironic that we're talking about this because literally I was talking to a staff member at one of the local assisted living facilities about a patient that I have who's living there. And the discussion was about, how do we increase water intake? This patient in particular has dementia. And so one of the things that I was talking to the staff member about was research that I've been doing to try to increase hydration. And she was like, is this a person who's with you right now? Or like you were just reading? And I'm literally, this is just what we do to illustrate your point is because we have the ability to just be doctors, it really frees up how we can be the doctor and advocate for our patient. And so I do have also patients who are like, I haven't talked with you in like 2 weeks and you just randomly emailed me about this thing that you read about some study on cardiovascular health or whatever. And they're like, oh my God, they're thinking about us even when we're not there. And it's so funny because this is what at least I could never really get into at the level that I would have liked to while in fee for service, because it was notes are never done. It was you're an hour and a half behind. It was all of these things. So I don't know if, that resonates with you and your patients, but that's definitely what it's ironic again, because I had that conversation.
Well, yeah, I mean, I have two stories. I can tell you two quick stories. One story is a patient that doesn't necessarily have dementia, but Parkinson's, and he does forget to drink. He has hypotension. Labs are a little bit off. He's a cardiologist. They try to put him on some medications, let's just say. And, I go along with it. One of my nurse practitioners that works here does IVs. So I just gave him an IV and his blood pressure perked back up. His coloring perked back up. So they come in once a week for an IV and the hypotension's improved. His exercise tolerance is improved because he likes to golf. Maybe that's why he's dehydrated. He goes out in Arizona sun and golfs all the time, but I can't limit that because you got to do what you got to love to do. The other story is my best friend in Arizona is a nephrologist, and we were watching a boxing match one night. There was a famous boxer from Omaha, Nebraska, and I told him, I said, and I went to commercial break, and I said, you know what? I got a really interesting case. I can't figure this thing out. I said, I worked it up as much as I possibly can. His labs are completely abnormal for the most common conditions. And he's like, well, you need to do a CT of his adrenals. And I did. And he's like, well, you need to do this. I go, I did. And then he looked it back up. And he's like, hold on a second. And he was Googling a little bit. He's like, this was on my boards. This is Little syndrome. He's like, I've never seen this before. So this guy's on 4 different blood pressure medications, can't control his blood pressure. And we diagnosed him with Little syndrome. I called the patient up 8:30 at night and told him. He was kind of like, what are you talking about? Right. He had no idea. But anyway, we put him on the new appropriate blood pressure medication, just one, and controlled ever since. And his mother passed away from a stroke because of uncontrolled blood pressure. And so it was really interesting how you said, you're right. We think about our patients outside, and that is patient advocacy to its fullest extent. What you do, what we do, what a lot of physicians do outside of DPC. But at the same time, we have the ability to spend a little bit more quality time to try to find the root cause of problems.
So with you realizing that quality patient care, advocacy, being a personal physician matters, when did you decide that you were going to leave your fee-for-service way of doing things and transition to direct primary care?
I think when my daughter was a freshman in high school, she got into soccer. I was a soccer player. And then during her practices, I remember pulling up my car, getting my laptop out, and then I would log in and I was doing all my patient notes. And all the parents were outside talking, and watching their kids. And then my daughter was like, did you see me practice? Did you see me? Did you take any pictures? I was like, no, I was doing my notes. And then I'd go back home, finish dinner, and then I would finish my patient notes and then repeat that process. And I have to say that at first I thought that was normal. But then I started to realize that this is not normal workload. And then when I looked at my practice as I was getting bigger and bigger, the more people that I hired, the more administrative work that I did, the more health benefits that I had to offer my staff, I was making less money actually growing my practice than I did as just having me and a couple other providers. I knew that this wasn't normal. Just constantly waking up in the morning, doing charting, my lunch during charting, soccer practice with my daughter, spending not quality time with my daughter. And I just said, this is not normal. And when I went to the meetings from the primary care groups and for like the accountable care organization it was just more and more documentation and more and more steering away from patient care. And I remember telling myself, why wouldn't I doing this if I was getting paid okay? But I'm not getting reimbursed and I'm doing extra work on top of it. And I'm not spending quality time with my daughter. There has to be another way. And I said, I love taking taking care of patients, but you can't live like this. It's not normal. I mean, one of my dad's saying is, if you retire, you expire. You really want to find something that you have passion about and you love about. And I think one of the things that I don't really appreciate with the system is that you see a lot of high quality, highly trained, super smart people retire early. And I said, I don't want to retire early. I want to be able to have a career that I love and that has longevity. I want them to kick me out of my practice rather than me retire. I said, there has to be a different way. I had meetings with the MDVIP group, met with me a few times. I knew the guy. Him and his son play soccer. I played soccer. My daughter plays soccer. So we talked, and I didn't like that aspect of medical legal complications with accepting insurance and cash at the same time. Plus, I thought that was a little bit of high fee. So I decided to look at other avenues. And that's when I discovered the direct primary care movement, and I researched its history. And then I kind of said to myself, this makes sense. So I went, I bought the books, and then I bought a book for every one of my staff members, and we all read it. And then one of my providers, she's amazing, Dr. Barker, she's like, this makes sense. And she's a Brown graduate, super smart. When she came along, and she didn't want to do concierge, but she agreed to this. And we set up a timeline. Our timeline was right around, I would say we were shooting for 6 months, but we did 9 months. So we did a lot of preparation. A lot of people, think, oh, I'm just going to switch my practice. Well, you can, but it does take a deep dive into the amount of patients that you have. How are you going to communicate your message, what your message wants to be, et cetera, as you know. And to make that final switch was difficult. There's no doubt about it. But once we did, then it became streamlined. Because at first, you care about it so passionately about it. But then after a while, it seems like once you get your volume of patients up, that you don't need to explain yourself so much. And if you just tell somebody, if you want access to high quality healthcare at a dime, you got it. If you don't, it's not the place for you. And I would say that a lot of my patients that didn't choose to sign up with me, they came back. They did come back. So, there is a waiting period for them to try out the other models, try out other doctors, and see the difference. So I think that's important, but it's also important to know that it is a process. It's not like something you can just do overnight. It takes time, especially converting a whole group, right? So we staggered it. So we staggered me transitioning first. Dr. Barker transitioned 3 to 4 months later. Then Dr. Summers transitioned 3 to 4 months later. And then Catherine, our nurse practitioner, she was doing a little bit of both, but she also runs a little bit of the wellness on the side. So some of the cash pay services that we do offer outside of the kind of the DPC model that she does.
Got it. And in terms of transitioning, we've heard statistics like 5 to 10% of a person's fee-for-service practice will follow them. Did you find that to be true between your practice and your other physicians' practices and Catherine's practice?
Yep. I mean, sometimes statistics don't lie, right? So, they always say, like, if you have a startup company, it takes 3 years to kind of see some fruition. And those statistics were spot on. I mean, the statistics out of the books that I've read were spot on. I think that we had around, let's say, 15,000 letters we mailed out. We got 10%, 1,500 patients. So it was spot on. And the books also say, like, the amount of phone calls you get is like double of what your patient schedule is. So if your schedule has like 4 patients on it, you get 8 phone calls. And so you usually get, 10 to 12%, 10 to 15% of your patient visits for your volume. But it also depends on you as a physician as well. So if you want your patients to follow up more, I mean, you can be busier. If you try to gear your practice toward like a lot of patient handouts, you just call me and do a lot of check-ins this way, then you'll see a lot less patients during the day. So you can, as you can structure a DPC practice that any which way you want to structure it. I mean, and you can have that type of practice with your patients that you like to see anyway. So, and then those patients will refer patients that feel the same way that they feel about their provider, and the list goes on.
I 110% agree with that. You earlier mentioned how, as part of your residency's reimbursement of your opening a practice, part of that was tied to you had to accept the insurances that they were accepting as well. So did you have to, before you opened your private practice, sign independent contracts with these, BUCA insurances? Or did you have an easier time transitioning to DPC because your name was just continued on with the residency's insurance programs and you did not have to unenroll in any BUCA plans?
The residency, the reimbursement had really kind of nothing to do with my practice other than just a little bit of a reimbursement. So I had to contract with Access, which is our Medicaid. I contracted with Medicare. I contracted with Alabuca. We had literally 3 boxes of health insurance plans that we had to cancel. And the irony, the funny thing was, is that the first time that the one that we canceled, we tried to renegotiate rates for like, I don't know, 3 or 4 times with Aetna. As soon as I canceled Aetna, the representative was at my doorstep the next day asking if they could renegotiate our contract. I'm like, I've been trying to renegotiate my contract for like 3 or 4 times with you guys in the last 10 years. No. See, what people don't understand sometimes is that when Medicare cuts their reimbursement, a lot of people at that level in Congress, they'll see the hospital systems. Oh, the hospitals are making too much money, or the hospitals are this, but when they'll cut their reimbursement rate, and then all of a sudden, like, what about us little guys? Because when you go into a hospital, you get a cup of coffee, you get lunch, the heater or the electric or the AC's on, the lights are on. But in our independent practices, we have to pay for all of that, right? And so you're going to cut reimbursement. You might dent a hospital a little bit, but you're crushing independent. But to your original question, I do think that I had to cancel each and every contract, and we had my office manager scrub every single contract that we canceled.
Yeah, and that's what my next question was. Any strategy tips that you have for those people who are looking to transition a fee-for-service clinic into DPC when it comes to unenrolling oneself or one's practice from the insurances?
I think the best way to do it is almost the exact same way that you signed up for insurance. One at a time, slow process, and reap the benefits of the money coming in that are delayed payments, as well as making sure your billing is looking at your accounts receivables and making sure that you're receiving all those payments and co-pays and that weren't collected, one insurance at a time. That's how my recommendation is. If you do it all at once, then it can get very cumbersome. I mean, we see it now more than ever, where you call up an imaging place, or you call up this place and like, oh, we don't take United Healthcare anymore. We don't take Blue Cross Blue Shield anymore. Well, so when you say that we don't take Blue Cross Blue Shield anymore, nobody's like really shocked anymore, right? So I would just do one at a time, slowly, consistently, and have a timeline. But when you opt out, you make sure that you're collecting all your receivables, you're calling all the patients, you're sending them out letters, videos, texts, et cetera, to tell them what you're doing and why you're doing it, and then the reason why you're doing it, as well as what makes you the best doctor for that particular patient.
Awesome. And when it comes to your staff transitioning to a direct primary care clinic, did you have any staff turnover in terms of, not needing billers and coders anymore? Did you have any people who were no longer going to be in one role, but could assume a different role under your DPC practice?
Well, unfortunately, you have to let people go. It's just the way that it is. Technically speaking, if you wanted let's say a patient, I mean, this is a hypothetical. If you wanted a patient panel of 250 patients, right, you basically can just open up your door, see a patient every hour, and don't really need any staff at all. If you wanted to have a busier practice doing more ancillary services, more procedures, you'll need a medical assistant, you'll need a front office. So we had to let go, I think, about 5 people. So most of those people that we had to let go, we actively pursued job replacement. So we actively called all the colleagues that we know, trying to find them a job. I gave them a little bit of a severance package for their hard work and helping us through this transition. So I didn't cancel their health insurance until 90 days afterwards. So they didn't have to get health insurance or the other benefits. Their day that they left, I extended that to 90 days. So I did a lot for my staff that stuck through it. But it is a sad moment. But there is a time when you have to take care of yourself in order to take care of other people.
So true. I absolutely have said that on the podcast before, because that's something I learned. I think it was even before I went to medical school. I think that's so true, and it resonates. And if that is a motto that helps you get through any overwhelm, entrepreneurship is not a smooth road just with no bumps. And so I think that that's something to keep in mind as you go forward. And now I want to ask about the people who did stay. So you mentioned your physicians who transitioned like dominoes after you, as well as Catherine staying. How did you transition their practices to DPC when it comes to finances? Did you have them stay on as your employees, or did they open up their own businesses under your practice name? How did that work out financially?
Well, I would say that when we transitioned the group practice and we also transitioned slowly executing the contracts to erase these contracts, I would have to say that our patient panels of her DPC were slowly increasing for each provider. And I think while we're doing that, the tricky part was trying to get each provider, DPC patients in first of the insurance, because they're like, wait a minute, there was a little confusion there at first. But luckily, my practice filled up really fast. Dr. Barker's practice filled up really fast. She had 500 patients within like 3 months. So we really had to close her panel. And then Dr. Summers was the last one, and he was a relatively new employee. So his panel didn't fill up as fast. It's 90% full now, but it took about a year or two for that to fill up. So I would say that I had to use some of my income to pay his salary just for a little bit of time until he ramped up. But that's an investment on my part, because what I normally see is that a physician who is happy with good benefits is not going to leave.
Totally. When it comes to the structure that you guys have, Dr. Barker, Dr. Summers, and Catherine and Kathleen now, I think, is also a nurse practitioner at your practice. Are they all W-2s now?
Yeah, they're all W-2s.
Got it. Continuing your team as employees, as W-2s, did you change benefits at all for them in terms of, did you switch to different offerings that were still as good quality when you transitioned to DPC, or did you just maintain the benefits that you had previously?
Nothing was changed. Not to say that I'm not going to change anything in the future, but nothing was changed. I provide everybody with good health insurance, dental, vision. I provide people with a bonus at the end of the year. I provide people with a 401k plan. So nothing's really changed.
Awesome. And any tips on setting up a 401k option for your employees? Because that's something that I know a lot of DPC doctors want to do, but they're not necessarily sure how to go about it because they've not been a small business owner before.
401ks are kind of strange because they're complicated, right? So I had an employee, and they said that one time, this is a true story. I had a physician one time, but they left to be a while back. They left to go to the ER room, become an ER physician at the VA. But told them, I give people 401k benefits, and then you talk to either your financial advisor, you can ask your banker, but they'll give you really good advice on how to set that up. And you don't necessarily need to take their advice. You can get a couple different options and then kind of look at it all together at a table, what you want to match and what you don't want to match. So there's a lot of options to do it. But what I didn't realize, though, this is that, if they leave in a certain amount of time, that money goes back into the 401k pool for the rest of your employees. It doesn't necessarily go back to you personally, but it goes back into the pool. I mean, it's not my area of expertise, but we did have talks on it. We did have a couple people from our 401k plan kind of educate our staff about that. And so I encourage everybody to do it, because is that you don't necessarily see the money you don't have, so you don't spend the money that you don't see. So, and over time it accumulates. I know, and most of my employees have been with me for a very long time, and their 401k is substantial now. So, and you can, as an employer, you can match 1%, 2%, whatever you want. And you can go higher if you want. You don't need to offer it. Some people just give people bonuses if you want at the end of the year. It all depends. But the only suggestion that I would tell a DPC doc that doesn't have an MBA is that it's not difficult. Take care of your staff that takes care of you. If you love your staff and you want them for a very long time, you got to give them great benefits.
Awesome. Now, as people were making the decision, now I'm talking about patients, to stay or to go, initially, when you transitioned to DPC in those first, 90 days, who are the people who transitioned over?
Just like the books that you read, the people that you don't think are going to transition to DPC, they do. The people that are bragging about their money and their houses and their finances and driving fancy cars, they usually don't. So you're like, what? I thought this guy had a ton of money. So to be honest with you, I would say that most people who want access to high quality healthcare that have a chronic condition, those people transition pretty rapidly over. They don't want to lose the rapport with you, as well as you're managing their chronic care and you know them very well. So those were kind of like, they need to stay here. And some people are surprised because they like you and they know you're a good doctor and they trust you. So, it's the whole saying, know, like, and trust. So that's important for people who sign up for your DPC practice.
Totally. And it goes back to, those people are going to tell people who are usually like them about your practice. And one, because they know the people that they're talking to. And two, they're probably hanging out with like-minded people who value similar things, access, trust, all of these things that we bring in DPC. I absolutely see that feeding into why word of mouth is a massive way that we grow our practices. So true. So now I want to transition to the fact that you offer a lot of services at your practice. And you talked about this earlier in terms of, you've taken care of migraines beyond Imitrex, but since before 2008, but you have quite a significant list of services.
I was big into integrative medicine aspect in the nutraceutical aspect of migraines. I worked with a headache migraine specialist, and we developed nutraceuticals for migraines back in 2008, 9, 10. That was fun. But I do think that a lot of doctors, family physicians, can provide a lot of services. I mean, we did a lot in our training. And this is the unfortunate part. We did so much in our training. And then as soon as we transitioned out to private practice, it's like, okay, these are all the check boxes. So it's like, but if we do the things that we did in our training in the real world, I think we can all do a lot of procedures. But go ahead. I try to do as many services as I possibly can in my office to try to reduce insurance claims if possible, unnecessary insurance claims.
Absolutely. And it goes into my question about how you found those services to be helpful to your community, because I'm wondering, looking at your services on your website, did you put these services because you either were already offering them or wanted to offer them, or did you add certain things because your community was asking for them?
Well, so I have a different view for primary care than a lot of people do, because when you learn about family medicine in residency in a hospital-based system, you are a part of that ecosystem of what they need you to be. So you need to do the things that you did in residency to be a part of that ecosystem. In the outpatient world, we have to learn how to take care of the most common ailments. And that's where my chiropractic degree really helped me out as well. Because like the most common complaint is back pain. So if you're not a master of back pain, we need to take seminars on how to treat that. Migraine headaches, it's the number one disability for like workforce on, missed absences. The cost is huge. I mean, so you got to know headaches, migraines is common. Skin lesions are common. Doing preventative measures is common. Everybody works out and they go to the gym, they do the CrossFit. You got to know your sports medicine kind of things, to treat that. And the injections are simple. I mean, they're not hard once you kind of learn the gist of them. So I just try to look at the most common ailments that people come to see a physician for. I mean, weight loss, it's huge. I mean, everybody should do a little bit of weight loss because it's so common. So these are the things that we should just get into, is just like, look what's inside the community, the most common ailments, and really master those. And that's why healthcare is different in each different state, because every state has their own set of unique circumstances, unique disease states. There's that occurs. You go to Hawaii and you get stung by some type of fish. They call me up on the phone. I'm like, I don't know. You might want to go to urgent care on that one, because I'm not really familiar with that type of fish that you're showing me a picture of. In Arizona, we have to check for valley fever more. You know what I'm saying. So it's all unique, but at the same time, you got to look at the most common circumstances and the most common ailments that people come in to see, and we should master those. I mean, you also have to look at what's kind of around you as well, and what you can refer people to, because I always try to refer somebody that can do a better job than me at something. So I think that's also important to know your limitations for your particular standard of care.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
Absolutely. And I think that goes back to the trust, like you mentioned earlier, being completely transparent and saying, I'm not actually sure, I'll get back to you, and following through with the I'll get back to you part. And then either saying to the patient, I can help with this, or I can help to a little bit more extent before you have to go see somebody else, or I need to send you to somebody else. And that absolutely is really appreciated. I know that from my patients, because we're so rural and access to specialists is so tumultuous and the waits are so long. And so the idea of maximizing what you can do under your training and what you're confident in adding to your repertoire of, to your toolbox, it just compounds so much in DPC. When it comes to your offerings for non-members, I want to ask about this as well, because some people ask about, how do you maintain finances if you're transitioning or if you're out of residency and you're not sure how to bring in income? For you, you have different tiers for direct pay non-members as well as your DPC patients. So how did you go about deciding what services were going to be offered for direct pay non-members, and how did you decide pricing for those people?
Well, I would say that it's a good question because we did that. What we're trying to do is make everybody members because they're going to get the most bang for their buck. However, some people need just one-offs, right? Which I don't love to do one-offs, but because there can be complications because they don't particularly follow up, So somebody comes to you and says, oh, I have this. And you're like, okay, I have a plan. I'm going to try these 4 things, but we got to try this one first. And then they go, that one didn't work. You're a horrible doctor. I'm getting out of here. Like, wait a minute. You got to have follow-up. It's personalized medicine and the fact that you got to try to cater toward you and try different things to find out which one best works for you. But anyway, so it all kind of basically started with the premise of a lot of plastic surgeons in Arizona wanted pre-ops. So we did pre-ops. And so we bundled our service. So a lot of our one-offs are pre-op visits from relatively healthy humans that need plastic surgery. Then we basically tried to shift the cash paying price. Unfortunately, we shifted a little higher because of the fact is that I value my time. So you're going to pay a lot of money for one visit and a lot of money for follow-up, or you can pay a really relatively reasonable fee for a monthly membership for us. So most people realize they just sign up for the monthly membership. So the other ones there are more of the nurse practitioners and other doctors. If they have a special area of interest, again, the AOIs that I like to call them, I give them free reins to do anything they want to do. They're physicians, they earn their degree. So if they want to do some cosmetics, go ahead. If they want to do lifestyle management or weight management, go ahead. If they wanted to do OMT, go ahead. We usually limit our OMT to 1 or 2 per month for DPC, and anything above that, we charge a fee. This seems only fair. But every physician, I give autonomy in the practice that they can do anything they want to do. But for the most parts, that's how it kind of went. I think we start off with everybody's coming in for these pre-ops, so we're charging them for that. And then we also say we want people to sign up for our membership. So this is our membership fee. And then everything else is a little steeped, a little pricier. So because we want people to sign up, we want more members. We don't want to go for another fee for service type place. That's how we worked it.
And I definitely would say it's very clear as day. We'll link your website to the blog accompanying your podcast, but you even have your direct healthcare membership menu that lists exactly what the tiers are, and it lists the membership. And if someone is looking at this from a financial perspective and understands not only having access to a physician, but also having that higher accessibility when you actually need it with someone who knows you, it's pretty awesome.
One more point to that, because when I transitioned my practice, the community doesn't realize what they have with DPC until they use it. And it's very difficult to place value on that until they see it. So for example, one of my elderly patients said, why do I need to pay you money when I already have Medicare? And I told him, you don't. You can go to another physician, but if you want access to me and talk to me and call me, he's like, well, I only come in once a year, which he came in more. But anyway, they all say that, right? It's like their thing. I only come in once a year. Okay, well, sir, I said, I've got 5 visits over here and you already called a dozen times, whatever, but okay, you see me once a year. I'm not going to argue with you. But anyway, so as soon as he said, fine, I'll do it. So he became a DPC. He calls me, every other week, he checks in with me. He goes, sees another specialist. He makes sure I gets the notes. Then he has an issue, he calls me, and then he came to me a couple of weeks ago and he said, I didn't realize how much I can utilize your services. And a lot of people do that. They'll call me about their supplements. So they'll call me about something the specialist said, and they want to check in because the specialist prescribed the medication, but they're already taking another medication. They want to see if they have any drug interactions. All these little things that people are calling me now for, just to make sure. And they're not very long visits. They're just quick questions or whatever. And they said, I never had the opportunity to do that before with a doctor. I'm like, that's what direct medicine, that's what direct healthcare, direct primary care is. It's like you have access now to make sure that your health is on point. So it's difficult to try to tell people in the insurance model what it's like to have a personal physician until they have it.
So true. Let me ask you here, when it comes to the fact that you are a personal physician, you are able to take care of a person on so many levels and use your pencil model. For those people who especially are already with a private practice and they're using insurance to bill for their care exclusively, what would you say to those doctors to really make them think about how they're practicing? You've mentioned so much already, but in terms of a takeaway message for those people in particular, what would you say to them to really think about as they decide to continue fee-for-service or do DPC in the future?
I think that in all honesty, we need both. There's no doubt about it. We can't be all or nothing. We do need both. I'll put it to you this way. We need physicians outside of the system to reduce unnecessary claims, to do more and be more for their patients, like I said before, to reduce inefficient care. We need somebody outside the system to decrease the excessive administrative costs. We need somebody outside the system to avoid fraud, as in all these referrals to all these other doctors, and you don't know where your patient ends up because you're too overwhelmed that you lose track of them. We need somebody outside the system to be a friend with the special medical knowledge to each patient, so they have somebody to refer to or ask if they're doing the right things all the time. But we all know it. As a DPC doctor, I'm sure that you got calls from patients and say, like, my pain doctor wants to do this injection, or this surgeon wants to do this. Should I do it? That is just double checking and triple checking, everything, or their medication. So you need somebody in the system, outside the system, to help with that aspect. Now, if a physician wants to go into a DPC model, there are soon enough, not exactly like I would say like right now, but soon, very soon, there will be group practices that are going to be hiring. There are now, but they're not as vast as the insurance model, but there's going to be group practices that are going to be hiring. And then what these physicians need to know is that when you're in the insurance model, you're constantly going to see, new and different people all the time and have to fill your schedule in order to make your paycheck. The DPC is basically, you have to get to your 400 to 500 patient mark, and then you're basically done, because your attrition rate, as some people fall off, the same amount of money, the same amount of people will reinstate with your DPC model. So you really need, just going back, I'm having another little moment here, but going back to your 401k, right? The doctor who chooses to do DPC is like a 401k because it's an investment. You invest 1 or 2 years, not making a lot of money to gather your 400 to 500 patients. You're basically invested for life.
It's so streamlined and so easy to understand. So I love that. So thank you so much, Dr. Rotella, for joining us today. We are going to be geeking out about efficiency and how efficiency in fee-for-service versus DPC is different and is not different. So join us over on the Patreon community for that. And again, thank you so much for sharing your story today.
No, thank you. Thanks for having me. Appreciate it.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Maryal Concepcion.